Hi, I'm Dr. Randy Martin with Northwestern Medicine's Bloom Cardiovascular Institute. I'm here at the CAST AF meeting, which is a new meeting that Northwestern Medicine has done, a fantastic meeting that's all on about the newest therapies for atrial fibrillation, which is a giant health problem. They have assembled a fabulous faculty, and one of the faculty members that's here is also a Northwestern faculty, is Dr. Susan Kim. Susan, thanks so much for joining us.
Thanks for having me.
So Susan's the Associate Professor and Director of the Cardiac Implantable Electronic Device Clinic and Cardiac Electrocardiography, so thanks very much. Susan, we're going to talk about pulmonary vein isolation, catheter pulmonary vein isolation to treat atrial fibrillation. There are various devices, various modalities. What is the type that gives you the best chance for long-term success?
So that's a great question, and I think a point of maybe there's some lack of clarity out there. Some people say it's this, some people say it's that. So currently our sort of two available modalities are either the freezing balloon or the cryo balloon ablation, or radiofrequency applied in sort of a point-by-point fashion. That has been a point of debate, which one's better. And actually there have been two trials comparing them head to head. The first one was the Fire and Ice trial that was published in 2016 that showed that in the end, actually the outcomes were comparable for both of them. They both had similar long-term outcomes in terms of first episode of atrial fibrillation. And the safety endpoints were also very similar. So from that point, in our minds, the technology, whether you use cryoballoon or RF point by point, were very similar. And then in March of 2019, the CIRCA dose study was presented at the European Society of Cardiology meeting. And that also compared radiofrequency ablation point by point versus cryoballoon in sort of longer versus shorter doses. And actually, again, the outcomes were comparable in both. For radiofrequency, the procedure time was a little bit longer, but the fluoroscopy time was shorter. And in addition to outcomes, the safety endpoints were also similar.
So it sounds like it's really dealer's choice, or who the physician has the most experience with that. You probably have a good outcome. Is there any does one of the procedures, cryo versus RF, have more complications? And I'm asking that as a novice.
Yeah, no, that's a great question. It turns out that if you look at overall complications, the endpoints are the same when comparing RF versus cryoballoon. The one difference is that there's a higher risk of phrenic nerve injury with cryoballoon, but that's well understood and sort of very closely monitored during cryoablation procedures. And as a result, the long-term, permanent injury rate is extremely low.
Yeah, you told me when we had a chance to talk earlier that, and I wasn't aware of this, that 95% or some percentage like that phrenic nerve problems will go away over time.
That's correct.
Okay,
that's correct.
So that's good. So that's very good information. Susan, let me ask you, so if I'm also looking at long-term outcomes or success rates, let's say, are there certain patient characteristics that would dictate who's going to be best for this?
Yeah. We kind of I give people sort of a gold, silver, and bronze medal category of sort of their long-term outcomes. And certainly patients who have what we call paroxysmal atrial fibrillation, meaning episodes that come and go on their own and are relatively short in duration, meaning hours, maybe a few days. Those patients are definitely going to have, longer-term success rates that are higher than in people who have what we call persistent atrial fibrillation, meaning that they go in and we have to cardiovert them or do something to get them out of atrial fibrillation. Other things that will kind of keep you on the gold medal category are having minimal structural heart disease and minimal comorbidities. Certainly being younger always helps as well.
So tell me, Doctor, what's minimal mean? So what's minimal structural and minimal comorbidities? I can envision that you're not talking about morbid obesity, obviously, but what's minimal structural?
Yeah, so we're looking at certainly left, ventricular size and function. That's going to be normal. The smaller and more normal the left atrium is going to be, the higher the success rates are going to be. Certainly the absence of significant left ventricular hypertrophy, valvular heart disease, all of those things are
Big time mitral regurg that's long-standing.
Exactly.
Susan, also, we had a chance to talk. I'm looking down at my notes because you educated me tremendously, that when we go back to looking at long-term success, there are certain things in there. What's the most critical for long-term success with pulmonary vein isolation ablation?
Yeah. So I would say there are sort of two things. Number one is, in terms of which technology is going to be better, it's the technology that physician is the most comfortable using and the most experienced using. Actually, Dr. Andrade earlier presented the circuit dose trial to us and showed us a graph that showed that with cryoballoon ablation, actually less experienced and more experienced operators had similar kind of long-term outcomes. But with radiofrequency, the high volume operators versus less experienced operators had a more disparate kind of outcome. And so definitely a higher level of experience and a high level of comfort, for that particular physician is going to help. And then I would say the most critical thing for anyone who takes care of people with atrial fibrillation, or if you yourself have atrial fibrillation, is to try to, address the issue of rhythm control as soon as possible. So the person who's diagnosed with atrial fibrillation, within a month or two, clearly has symptoms and needs rhythm control, getting that person referred for, appropriate rhythm control, whether it's antiarrhythmic medication or catheter ablation, is going to be a huge advantage versus, maybe I'll leave you in AFib, 2 years later, the left atrium is dilated, it's going to be, exactly, it's going to be much harder to get success.
So you're saying, which I think is really important, is you're saying that earlier intervention on the rhythm, and it doesn't necessarily have to be catheter ablation. It could be antiarrhythmics is really important.
Correct.
At what point do you move from, and so if you're doing, so somebody comes to the ER and they have this, and there was a study out recently that said you can wait a little while to see what happens with them in the ER, but at what point do you move from antiarrhythmics to catheter ablation in people with proximal AFib?
Yeah, that's a great question. So, and just to take even one further step back, is there's definitely a population of people with atrial fibrillation who don't need antiarrhythmic drugs or catheter ablation, who can just stay in atrial fibrillation. And those are people who are appropriately anticoagulated. That's always the first question to answer. They're appropriately rate controlled, and they have no symptoms, and their heart is not suffering from their atrial fibrillation. That population of people can simply be rate controlled. We're talking about people who are suffering because of their atrial fibrillation. They're short of breath, they're not exerting themselves as much, or their hearts are showing signs that they don't enjoy atrial fibrillation. The ejection fraction is down, they're short of breath. And in terms of when to switch from antiarrhythmic drugs to catheter ablation, it's the people who ultimately kind of either break through their drug, meaning we put them on their medication and they just keep having atrial fibrillation, or there are people who may be well controlled but they don't tolerate the medication. It may suppress their heart rate too much. Younger, more active people oftentimes prefer to consider ablation versus medication.
That's good. A lot of good information. I mean, I think I've learned, I know our viewers have learned. Thank you very much. And thank you for watching, but I want you to stay tuned because there's a lot of good information, new information like we just learned coming out of the CAST AF, and we're going to have more for you. Thanks very much.